lots about films, and I think somebody's going to come out and award somebody an Oscar for cinematography in medicine. In any case, let me tell you a little bit about Dr. Palter. He's the founder, medical and scientific director of Gold Coast IVF in Syosset, New York, and the former clinic and chief of infertility at Yale University School of Medicine. He founded and is the program director of the Center for Excellence Program in Gynecologic Minimally Invasive Surgery. Dr. Palter's passion for technological innovation is well known, and he performed the world's first HD and 4,000 surgeries. It's a great honor to introduce Dr. Palter.
Thank you so much for that kind introduction, and thank you to my friends, Tamir, for the invitation to be here, and my colleagues and friends who have spoken to you before. As you mentioned, I'm a reproductive endocrinologist. I'm a fertility specialist, but I work in multimodal therapy, surgery, IVF, whatever we need to accomplish our results for patients, either to get pregnant or to maintain their fertility. And what I'm going to talk to you about today is to take the introduction that Dr. Septibal gave you on how film and medicine set the stage for this collaboration, and then show you what came next, how we moved through the 1900s to where we are today, and to give you a vision of where we're going to go in the future. I'm not going to talk to you so much in a data-driven lecture, but I want to give you a vision of how the marriage between technology and film has changed surgical practice, and I want to show you why everything that you do today will, within the next decade, be really obsolete, and why, instead of that being an area for fear, you should see this as perhaps the greatest opportunity for change and transformation of care of our patients and how you perform your surgical practice that we've ever had. So I'm going to talk to you about the innovations in cinema and their impact on medicine, why laparoscopy has fundamentally changed the mindset of the surgeon, and share a vision of how technology transforms surgery. And so what I'm going to give you now is really a visual journey starting from where Dr. Septibal was. So if you look back in the 1900s to 2015, I think what we had was, I call it a continuum of interactivity. You basically had a picture on a screen and you brought it in, and then the audience sat there. And as time came, what I'll show you in my first videos, also rescued from some of the US archives, is how the images got better and better, approaching what you could do with your eyes and your hands. And so in Hollywood, with some of the people that we collaborate with, and in video technology, we increased the realism in sound and color. But where future technology is going to go is beyond both immersive reality and beyond the natural abilities of the surgeon, where instead of the technology just being a tool to approximate what you do, it will actually enhance what you could ever do. And so Antonio showed you the Lumiere brothers, and he showed you this film of the first film that was shown in the Paris Grand Café. The point I want to show you is that the reaction of the audience was remarkable when this was shown. At this point in the movie, the crowd was 35 people or so. 3/4 of the audience stood up and ran out of the room in terror because they were sure that they were going to be crushed to death by this oncoming train. You see, in their world set, in their mind, they had never seen an image of a train coming at them on a screen. There had never been a motion picture on the wall. And so to them, this seemed so real that they were sure that actually a train was coming through and they would be crushed, despite when you look at it now, it seems absurd. And I'm going to show you why in 50 years, people will look back at what we're doing today with the same mindset at, my God, how could anyone believe that these were images? This was the most crude, rudimentary things that we had ever seen. And so let's talk about the marriage of endoscopy and film, because nowhere more in medicine than endoscopy have the two been together. Now, this is a film that we rescued from the American National Archives and the National Library from the 1930s. This was the first coupling of an endoscope to a camera. I mean, look at the size of that monster. And it was a film camera, and it was right at the time when Gone with the Wind was coming out. So in the late 1930s, they basically used this, just as Dr. Septoval showed you, to educate and to show people how procedures were being performed. So then, this is one of the first uses of this. This is, by the way, they're using cocaine as local anesthesia. That's what they used at that time. And the patient's blindfolded, and they say it's, you have to restrain them. And here, they're recording the film for teaching abilities. And again, no one had ever seen something so realistic as this. In fact, there was a backlash saying, perhaps this is inappropriate to show something of such real candor in a public meeting. So it then made it to this point. And this was rescued from one of the German archives. And again, we've switched our machines so much. Hopefully they'll all work. Let me go back. This was rescued from a German archive, and this was the first laparoscopy that was recorded. You'll see the patient is strapped down when he comes in. The technique is quite a bit different than we use today. They use room air with a bellows to insufflate the abdomen. And what the commentary in German said in this is they are remarking at the miraculous image that is akin to what you could see with your naked eye. And they were performing biopsies of peritoneal tumors to confirm the diagnosis of cancer. In 1971, this was the first, from Upjohn, the first laparoscopic teaching film. And again, the same comments.
Laparoscopy is indicated in cases where routine diagnostic procedures fail to reveal the cause of acute pelvic pain and for tubal ligation. It is especially useful in differentiating between acute pelvic inflammatory disease, physiologic ovarian cyst, and tubal pregnancy.
So in 1971, that was state of the art. And when that film was shown at the AAGL National Conference, people suddenly realized that you could do things with video that would be akin to your eye, since the video was as good as your eye. But what I want to show you is how the marriage of technology enabled things to happen that previously would have been impossible. And this was a film that I found in the US National Archive that was labeled Miscellaneous Surgical Video. And what it actually was Patrick Steptoe, of Steptoe and Edwards fame, who invented in vitro fertilization, performing the first procedure where they did the first egg retrieval that he said was possible because of laparoscopy and his first attempt at getting an egg. And you'll see the equipment that they use.
The examination of the abdomen by means of a laparoscope has proved to be a most valuable diagnostic advance. One of the most important recent developments is the recovery of oocytes after priming the ovaries with gonadotrophins. First of all, the ovary is held steady in position, the follicle is punctured, and the contents are aspirated at a low pressure so as not to damage the oocyte.
And there's the first recorded egg
The
retrieval
needle with a
before
very
IVF
short
had ever
bevel
worked.
is introduced into the follicle.
Now, I had the pleasure of meeting Steptoe and Edwards, and Edwards said, and I'll quote, "I read about this chap Steptoe and his work with something called a laparoscope. He was writing about how he had managed to reach the fallopian tubes, and I thought if he can do that, he could reach the ovary and we could invent this new procedure." So it was the ability to have the technology to perform laparoscopy that gave them the idea. He actually watched Steptoe do a video of laparoscopy, and he had the idea that IVF could come. Well, where did this come from? What was the reaction of the traditional surgeon when he saw his first laparoscope? I mean, Harry tells us stories of when he performed these miraculous, wonderful procedures that cured the patient, and they said, "You must be insane, we'll have to put you in jail for doing this." Kurt Sem had to have a CT scan of his head because they said, "You must have a brain tumor to think of doing this procedure," well, even though it actually worked. And so what uses did the first laparoscopic surgeon imagine, and where did the technology come from? I guarantee you, when this technology was invented, no one had the beginnings of a thought that we could do anything but look inside. And it actually was the same path that occurred in technology outside of medicine. And that's something I'm going to show you, is how progress is ever accelerating, how the rate of change is accelerating in the world, and the difference between 1970 and today will now occur in just a few years. Well, this is Boyle and Smith, and they worked in Bell Labs in 1970, and what they're showing you here is where they invented the CCD, the charge-coupled device, which was the chip in our cameras. This camera you see to broadcast, this is the camera in the operating room. They won the Nobel Prize for this, and what they were trying to invent was a video phone. They weren't trying to do anything for surgery, but then the surgeon thought, perhaps we could couple these technologies. This is something called analog transfer. You take a technology from another field and you bring it into your field to change the mindset of how you do things. Now just think about how fast technology is changing. Look at your cell phone today versus where it was 5 years ago. The same thing is going to happen with our surgical tools. Because in fact, this was the first VCR. That's Ray Dolby with his Emmy that he won for this. It cost $50,000. It was the Ampex 1956 year, VR1000. It cost $50,000. And the only use of it that could be imagined to invent recording was to record the news, and Douglas Edwards was the anchor, and to show it later, a few hours later. There was no thought that anyone could come up with of why you would ever do anything with this. But look how, once the technology existed, new uses, new procedures, and new medical uses came out of it. So medical endoscopy is an outgrowth of commercial broadcast equipment. Film, video, and medicine were married, and this was Cameron Najat. With the first camera he used, it was actually hung from a boom in the ceiling because it was so heavy. And I'll show you a little bit how we took that idea to do this project again today. So this is the first course from the first series. This was found in an archive in Hawaii in the early 70s, where they said video would be for mentoring. And this was the first resident training, and this was the view of the pelvis. And what they comment on is, again, this is the most remarkable realistic image that they've ever seen in their life. Nothing could be better than this. And they said, look, this is the first time we actually had a color image. Your cameras used to be black and white prior to this. So you see they used the black and white cameras to get increased resolution, and then they switched to the color, and again, that's the camera that's being used. And it was just, when we look at this now realize this is 1970, so it's 40 years ago. This is not 100 years ago. This is 40 years ago. And when you look at this in the room, it's incomprehensible to you that this could have been in your lifetime when it's so utterly primitive and poor quality. So let me show you the theory I have of the technological transformation of surgery. Thomas Kuhn, in 1962, wrote a book, The Structure of Scientific Revolution, where he coined the term paradigm shift. That's thrown around a lot today, but what it means is that when something occurs that shakes up your whole view of the world, such that it not just gives you an idea, but your whole system of doing things no longer exists, and changes will occur in your entire worldview. And what I'll show you is that laparoscopy is that point for all of medicine. Since antiquity, the surgeon's mind, there was a direct interaction between the surgeon's hand and the patient's body. There was an incision made, the surgeon stuck his hand in just as Doyen did, and he cut something out. And I'll tell you, from 1700 to 1970, very little changed. It was the same idea. You made a cut, you put it in, and all that changed was the suture, the antibiotic, the clamp, but there was no radical change in how things were done. You were guided by your traditional senses and feedback. So the OR of 1950 was no different than the OR of 1850. The laparoscopist's mind completely changed that, because for the first time now, there was remote instruments viewing the procedure on a TV monitor. And in my theory, laparoscopy is a pivotal clinical point where the surgeon no longer is directly interacting with the patient, but there's technology between him. Well, what does that mean? It means that surgery can be fundamentally transformed, because a knife can't change very much. A clamp can't change very much. But microchip technology follows Moore's law, and it increases exponentially. So once you put computer chips between you and the patient, suddenly there's no limits to how procedures will change. And so the indirect interaction between the surgeon and the patient through a mechanical and electronical interface is a fundamental paradigm shift in medical care. It sets the stage for technology could then modify the interface. So this was Colonel Christoph Kaufmann working in DARPA when they made the first robotic surgery. This was the precursor of the Da Vinci. And so if technology is between you and the patient, then a robot could be there. You could, in fact, simulate the interface. If technology is between you and the patient, you could eliminate the patient and reproduce the surgery for training. Has endoscopic surgery maxed out? Have we gone as far as we can, or can we reinvent surgery? So now I've brought you up to the point where we're now at 2012. Let me show you where I think we're going to go in the next 10 to 20 years and how I believe we will reinvent surgery. Well, in my technological theory of medical progress for the 21st century, the digital revolution is now upon us in medicine. I showed you how technology is in the interface. And we have now entered the exponential growth phase, where I will show you why I believe that we will have an order of magnitude 10 years progress in 1 year as we move ahead. We have actually mathematically modeled medical progress and surgical innovation and compared it to what's happening outside of medicine and showed that the same rate of rise that's occurring with your cell phone will occur with surgery now that there's technology involved. Well, Moore's law said that computer power, the number of transistors on the chip would double every 1 to 3 years, and it would be at a lower cost. So basically, technology is not 30 times less than it was 30 years ago, it's 8,000 times less. And so if you Moore looked at processing power, and he said and remember, this is a logarithmic scale, that it's an exponential rise, 10 times rise in 1 unit of time. And that was computer chips. But what we don't realize is that Ray Kurzweil demonstrated that this doesn't take place for just computer chips, it's actually all information technologies. They all double their power, performance, capacity, bandwidth, while reducing costs over the same time. So Ray Kurzweil took us back to 1900 and just looked at calculations. They looked at cathode ray tubes and the ancient computers going up to the microchip and showed that Moore's law is actually followed with all computing and electronic devices, even predating microprocessors. Everything would double every 1 to 3 years. He then showed a remarkable study where they took GenBank gene sequences. And again, this is the logarithmic scale. And what they showed was that, again, if you looked at the number of DNA sequences that have been sequenced in the world, it's following the same exponential rise. This was an amazing one looked by Dickerson looking at protein models. And what they predicted was that if everything was following an exponential rise, in 1978, they predicted how many protein sequences would be solved by the year 2000. They predicted 4,201, and it was 14,250. So Moore's law applies not just to your computer chip. Anything that uses technology to process information is following it. DNA sequencing, protein sequencing, information technology, and GenBank. We applied this to medical publications. We looked at the National Library of Medicine and showed that around 1985, medical publication went from being linear to being exponential. So in the mid-'80s, we actually shifted from where you were getting 10-fold increase in 1 unit's time in medical publishing at all. And we looked at the same thing with the rate of endoscopic innovation by patent applications and showed that once you hit 1980, it hit an exponential curve again. So as predicted by these people looking in computer science and in gene sequence and protein science, medical technology and medical publications have just entered the exponential rise. Maybe that's why when you went to a medical meeting in 1970, if you were going to them then, everything really looked the same, and every 5 years there'd be something interesting. And now when you go to a meeting, it seems that every 1 or 2 years there's something radically different that you didn't see before. So let me show you what does this mean where we will go in the future. I believe that we will augment our abilities with technological surgery, and this will start with imaging and resolution, bring us up to the ability to look at the resolution of your native eye, and then within your lifetime go beyond what your eyes and hands can do. So you heard in the introduction, in 2000, I performed the first HD TV laparoscopy. It took me a year to convince the engineers in the Japanese broadcast companies to let me have the camera. In 2000, every single device manufacturer that makes endoscopes and every single company that makes video cameras told me this was an absurd idea. Why would you ever do that? Who could ever see anything better than we see with our cameras? And I showed you it was the same mindset in 1970. So we finally did it, and people were shocked that the image was 5 times sharper, and now it's become a standard of care. And we know from work that endometriosis, David Redswine work, that small lesions exist and you might not be able to see them. And basically we know if you can't see what happened, if you can't see, you don't know what's there. So the better you can see and the better you can judge what happens, obviously your outcome will be better. So then the same thing happened again. I thought to myself, well, why should HD be the limit? Because your retina is probably 100 times better than that in resolution. And again, all the medical equipment companies told me, one, what a stupid idea. Why would you ever go beyond that? And then the engineers also told me, my poor ignorant doctor, it's impossible. And so as someone who works in fertility innovation, perhaps the biggest excitement challenge I get is when someone tells me that there's a wonderful idea, but it's impossible, because that is a challenge. And so we sought out to do so. And I flew out to the National Association of Broadcasters and met with the people in Hollywood that had taken our cameras now, not to HD, but to 4,000 lines of resolution, 4 times HD. And so Hollywood is now filming films in 4K resolution. I'll let you know that there's been $1 billion invested in new digital theaters to install this technology, and they are now running at that kind of resolution. HD is about 12 megapixels. These 4,000 line chips are 4 times that. And so what we did was, this was their video conference. They have 120,000 people come to the Hollywood and TV conferences. There was one doctor there, and I went through the halls, and I met the head of the company, and I said, I think we could change how we do imaging in medicine with this. And so that camera that Dr. Setubal showed you, this was the red camera, and what they did was they went to 4 times HD, and they reduced the cost according to Moore's law. The previous competitor was $200,000. They produced it for $17,000. And they wanted to turn movie making into desktop publishing, which they've already done. And this was the projector we used. This was the Sony projector. It's a $100,000 projector. We did a pilot study where we had this stuff installed in a medical conference. And this was the camera. So the first pilot, we suspended it just to shoot into the wound, and we said, could we see anything? And we saw details that we had never seen before, because we had 4 times the resolution, but it was magnified 1,000 times. So it was better than my eye was seeing. And I was amazed at how different it was than what we were used to seeing. And look, we did it in surgery, and look how remarkably similar this looks to when Cameron Najat did that. The same idea, this enormous 15-pound camera, we took the old couplers, we built an interface, and we performed surgery in 4K, and we showed that the images can be that much better. So now this camera has been reduced to be about this size, and instead of 4,000 lines of resolution, they're up to 16, and they'll probably hit 25 soon. And so there is no reason why within a few years these will be miniaturized again enough to be able to be placed in a surgical endoscope, and we will have again a leap of difference in resolution between HD and 4K that we had from the 1970s to today. But we can do much more because these are digital. So what we can do, and again, there was the boom. We had to first suspend it because it was so heavy. So what we can do is we can then overclock the sensor, and we can do ultra-high resolution slow motion. So since it's all digital, this is just the camera shooting. I just shot it. I said, shoot it at 4 times normal speed and then digitally slow it down. The Hollywood people told me, and they showed me their prototypes where they can go 120 times real time, slow it down, and the military people showed me that you can then image process this and have a computer enhance it, because that's what they're doing with the drones. So when something's happening very rapidly, you could have a stroboscopic camera that's running at 120 times the rate that your eye could see it, and there could be energy sources firing to treat the pathology that your eye isn't even able to keep up with because it's digital. Well, this is what we did with it in the IVF lab. We basically took that miniaturized camera and we installed it into incubators, and instead of looking at an embryo once a day, there's a 24-hour time-lapse image of the embryo moving. And what was shocked everyone is we make decisions about how to grade an embryo based on how it looks at a 1-second time in its 5-day development. What this movie showed us, that 5 minutes earlier, it had a completely different appearance and the cells were trembling and changing. So the use of the technology is completely transforming how we process the information. So let me show you now what this means we can do going into the future. The next revolution, I believe, will be to really come up with transformative technologies that can really be revolutionary. And I want to ask you if you can think of those.
You have to let it all go, Neo. Fear, doubt, and disbelief. Free your mind.
Whoa. So if I'll challenge you, if I challenge you to take everything that you believe is fixed, there's an idea in innovation called functional fixedness. It means that you're used to seeing it one way, so it can only be that way. For example, your phone had to be a certain size because there had to be room for the keyboard. Well, what if there can't be a keyboard? Well, then the touch sensor of the iPhone gets invented. So let me challenge you to get away from your fixedness of what you think is required. And I'll show you the idea of future vision. Here, the idea is that you take your innate senses and your natural abilities and you go beyond them with technology. So here's what the US Olympic team does. This is an actual training video. They time-lapse it with the cameras I showed you, 120 times normal speed. The computer traces it, but then the computer tracks the trajectory, and it tells them with minute precision, and can actually, this is from a physical therapy, they can actually track the athlete's performance, and they can improve how the task is done. Well, what is an athlete doing? He's moving something to get a performance outcome. So what the Olympic team and pro sports have done is they have these cameras installed at the baseball field and on the tracks. They film it, they speed it up, and then they computer enhance it, and the computer then tells you how you can perform better. The military does the same thing. So this technology will be transformed to medicine, and here's the idea of where we're going. This is my arm. This was a near-infrared camera, and on the top, that's my arm. That camera in real time is seeing the blood flowing through my veins, but it's invisible to my eye. It's a wavelength of light called near-infrared light that can see the reflection of the blood, and so this was commercialized into a product to put IVs into cancer patients and pediatric patients with no blind sticks. That camera sees what my eye can't see. It's gone beyond my innate abilities. Here was a pilot study Doug Ott did, doing the same thing, looking for the ureter. Invisible light, that's a mouse, that's the mouse ureter. They tagged a monoclonal antibody against the proteins on the urothelium, and it showed up in near-infrared light. And then when you merge the two and look through a camera, through an endoscope, the ureter glows through the peritoneum, and it's not really glowing, it's just seeing wavelengths of light that your eye doesn't see, the same way a cat can see at night. So we applied this principle to endometriosis next. In autofluorescence, the idea is that photons of light interact with matter and they reflect it, but a little bit of it is changed and released at a different wavelength. So the concept was, if light is released at a little bit of a different wavelength, whether the tissue is normal or different, couldn't we invent a camera that sees that 1% of light that your eye doesn't? So here's how it was done in the bladder. In the bladder, they had a photosensitizing dye, and bladder tumors were illuminated. We used this idea in a pilot project for endometriosis. So the idea is that light is reflected off the peritoneum, and there's the lesion. And you look with your eye, and you see a little bit of disease. But what happens is, when you use filters, you can augment the amount of light that the tissue itself gives off. This is happening naturally, but your eye can't perceive it. And then by using a complex system of filters and just ordinary light, we were able to make disease that was invisible become visible to the naked eye. And there was the true extent of the endometriosis. Now, maybe in the most experts' hands, the people in the audience here, you would have seen that disease, but other people who are not as experienced might not have. And so here's an example of what the lesions looked like. You can see some of it is dark and some of it glows. And this was something we called the firefly effect. This was microscopic endosalpingiosis that was invisible to the eye that autofluoresced itself. And so for the first time, we were able to see additional endometriotic lesions and additional disease by using a technology that saw things that my eye couldn't see. And doesn't that make sense? I mean, why do you think that your eye can see everything there can? I'd rather have a bat or a cat looking in there, a dog listening that can see things that I can, and technology will do that. So here's an example. This is a prototype. This has just been released where it's been added to the robot. And this technology is being used for blood perfusion. In this, you'll see perfused tissue glows. You're seeing tissue that actually has blood flow that would have been invisible to your eye. In the IVF lab, we're doing the same thing. My colleague, when I was at Yale, David Keefe, developed a pole scope that saw cellular details inside the egg that were invisible to your eye. And we're going to go there. We're going to be able to see DNA structures that you couldn't have seen. So that was the first revolution that I wanted to share with you. That was taking something and going beyond what your eye could see. The next one is going to be miniaturizing it. We did a pilot study in the early 90s where the scope became digital. So if the scope is digital and it no longer needs lenses and cameras, then the scope doesn't have to be shaped like a scope. It could be implanted or put anywhere inside the body. And so people had the idea of doing natural orifice surgery then when the scopes could be flexible, and they actually did appendectomies by going through the person's stomach and pulling the appendix out through the mouth. But the problem we have is when we think of robotics, you know, these are robots. I was at a technology meeting where they wanted to show me things, and you know, the Japanese ideal on the right there was they made the robot look like Albert Einstein, make it look like the smartest human. The one on the left from the American company said, we modeled all the muscles in the human body, and so it will be as good as your hand. And what I said to them is, I want the one on the bottom. That's an industrial robot that was used to build cars where it was pure function over form. This one was trained to be a DJ. And I said, I'd rather have an industrial robot that can perform the task better than my hand can perform. So this is the robot we have today. It mimics your human hand. And this is robotic surgery. It's a remarkable tool that can allow you inside to do the exact movements that your hand can do. And this was thought to be a revolution. But what I'll tell you is I think it's more of an evolution, because where we will go next, if you look at how industrial robots are working, how military robots and drones are working, it's function over form. So in that case, you would have these kinds of devices developed. You have a scope that can have multiple elevating and manipulating functions inside. It's not supposed to look like your hand. In fact, it can look like anything because it's now digital, flexible, and can be moved. So this was the one. This was the Cobra, where it's an endoscope inside the peritoneum that's actually, in an animal model, suturing with its two arms. And in fact, this was one that I thought was the biggest breakthrough. They wanted to have something that could do colonoscopy, so they actually modeled tapeworms and insectoid parasites, and they swam up the GI tract. So I would rather have something that takes this form, an insect or another type of technology that doesn't mimic my hand, because it will be able to be put inside the body and move places that we couldn't move on our own. And you know, I know what you're thinking. There's, you know, some things you can do just are stupid. You know, just because you can do something, it doesn't mean it's a good idea. And so we obviously have to test these things, and we have to prove that they'll be better. But we have taken scopes and miniaturized them. This is a falloposcope study I did where we miniaturized it and we looked inside the peritoneum. And this is capsule endoscopy. They applied these principles. You swallow a capsule that has the diagnostic yield now 30% better than all other technologies, because it doesn't have to look like a scope. It goes through your body and it images the GI tract. And it records, you can see polyps in vivo here, and the new technology, in fact, what it does is it actually records where the pathology is, tags it, pulls up an atlas, and tells the gastroenterologist, we think this is this kind of tumor. Don't look at the 8 hours, here's the 10 seconds where the pathology was, and the thing just records it. And so this is actually surpassing the diagnostic yield of upper GI series and upper endoscopy. It reminds us a lot of Fantastic Voyage. If you ever saw that movie, where will it lead us? We are on the verge now. The technology exists in military where we can have remote devices inside the peritoneal cavity that are sampling or releasing therapeutics, that are releasing chemotherapy. And so in Fantastic Voyage, you miniaturize the camera and the surgeon, and they miniaturized the surgeons and injected them into the bloodstream. It's not the surgeon that's going to be miniaturized, it's going to be the tool that's miniaturized. And that tool will exist. It already exists today in the military. Because think, we've put a rover on Mars. There are cameras now that work in swarms that are the size of a fly. You can release 1,000 of them over a city and collect all the images and transpond back to a military base. So actually putting something into the peritoneum is not even a challenge technologically. It's just not developed into therapeutics yet. This is an actual prototype of one that would go inside the body and be remotely moving. So let me show you the last step of where I think this will go. What could be even better than miniaturizing things? Well, we're at the verge where we will actually replace a lot of it with even virtual endoscopy for diagnosis. So what you do is you do a high-resolution CT scan, and you stack all the images, and you tell the computer, you know what, just put it together and give me the pictures of any angle and see things that I couldn't see if I was looking inside. Retroperitoneal fibrosis, deep infiltrating endometriosis. Don't look at the surface. Make a map with technology beforehand. So here's what happens. If you do a regular CT scan, it's curved and you can't see the spine. But I can now tell a computer, take a CAT scan, follow the curve of the spine, straighten it, and give me a view that I couldn't see with a flat plane. Well, what does that mean? Well, here's what it means to the bowel. You could take a CAT scan in a single breath hold in a few seconds, and you could tell the computer, well, simply separate air, lung, fat, bone, and you can also tell it today, by the way, look at the infiltrating fibrotic tissue versus natural tissue because it's got a different signal characteristic. And you could tell it, give them different colors and separate them. And if you do that, here's what will happen. You can take a CAT scan and say, give me a 3D image of the bone. Give me a 3D image of the bowel. Give me a 3D image of the bowel without the bone. Well, in fact, give me a barium enema. Show me what the surface looks like. Show me what it looks like if I was looking inside with my eye. You can go even further. This is a man sitting in a CAT scan, and I just peeled away his tie, unbuttoned his shirt, his skin, his bones, and then his soft tissue. Now remember, the CAT scan and the MRI is increasing exponentially. So the machines we have now are 100 times better resolution than this image that I showed you. So in virtual colonoscopy, you take that image, and then you reconstruct them, and you tell the computer, convert it into a 3D model. So there's the virtual barium enema taken from a CAT scan. It's been shown to have the same diagnostic yield or better than an X-ray. And then you could say, you know what? Show me the path where the camera would go if I stuck an endoscope inside. And in fact, show me what it would look like if you just reconstructed. And there's the polyp and there's the tumor. Because the data is all there. So the computer can process it and show it to you in any way. And the computer and the imager can now see better than your eye can see. Well, in fact, one of the problems is polyps exist behind folds in the bowel. So if you put a camera in, you may miss disease. You may miss disease if it's there. So what you can do is you can tell the computer, well, can you just look up, down, in, out, and backwards at the same time? And as the patient has their breath hold, here's an example. That's what you would see if you did a colonoscopy. But the computer can show me up, down, inside, out, and backwards at the same time and then pick out where the disease is that you would have missed. In fact, you can tell it, could you just take the bowel out of the patient, cut it open, and lay it on the table and show me what it would look like if I did a colectomy? Well, you can, because this is a virtual pathology specimen. That's a real person, living patient, and there's his bowel filleted out on the table, and you could see the pathology that you could never have seen if you looked inside. You can do the same thing with bronchoscopy. You can do the same thing with angioscopy. And we do the same thing actually every day in the uterus. This is a septate uterus with a polyp that I did a 3D reconstructed view and saw angles that I couldn't have seen with my eye. And this is just my ultrasound machine on the floor. If you actually look at it, did you know that the PlayStation 3 has the processing power greater than the computers that sent the people to the moon? So actually NASA now has NASA and one of the National Institute of Health, they just networked 100 of them and said, you know, let's use that graphics ability and see where we could go for healthcare imaging. And it's actually an order of magnitude beyond what we see here. So we do this now. We see our babies in 3D in utero. And where we will go in the future is basically, again, going beyond what your eye can see non-invasively, imaging the disease, mapping the retroperitoneal fibrosis, then sitting down at a simulator, practicing the surgery on that patient's own data set, and then going in and reproducing the image as the computer tells you where to be safe and where to see the disease that's invisible to your eye. So hopefully, as I showed you, as we blur the borders between reality, virtual reality, using this entertainment and military technology, I hope you have the idea. My challenge to you is if you look at 1911 or late 1800s in the films of Doyen that we saw at the beginning, I showed you the 1970s of the images of where we started endoscopy. How different is surgery today from 100 years ago, from that laparoscopy Doyen with the ether drip, with the blood dripping out? How different are we from 100 years ago? How different do you think surgery will be 100 years from now? The models that I've shown you are all clinical trials that we have completed with existing off-the-shelf technology. I think in the future, we are clearly in a logarithmic phase of progress, and endoscopic surgery put the computer there. So medicine will really be transformed, and we can imagine the unimaginable and blur the reality to improve our outcomes for our patients beyond our innate abilities. I'll finish up with these two quotes. Eric Hoffer said, in the time of change, it's the learners who inherit the future. The learned who know everything find themselves well-equipped to live in a world that no longer exists. And Mark Twain said, 20 years from now, you'll be more disappointed by the things you did not do than the things you did. So throw off the bowlines, sail away from the safe harbor, catch the trade winds in your sails, explore, dream, discover, give yourself away to the sea of the life. Don't assume that anything you do is the way it will be in the future, and see that as a time of unparalleled opportunity. I want to thank all the collaborators we've had from around the world, from the technology companies that help bring you these demonstrations. Thank you.
Thank you, Dr. Palter. Are there any